peace, gratitude, and highest heart love. Welcome back to the YouTube live reading of Poverty, Ethnic Identity, and Healthcare. I'm your moderator and narrator, Uriel Neveu. Thank you so much for being here for this live read. Yeah, we're picking up in the third chapter, and where we're picking up is just so critical to where we are today in our world. So, this chapter is called Black Americans, and where we left off yesterday, peace, highest heart, love, gratitude for being here and reading with us. We left off yesterday at page 48. And right before that, we had saw the life expectancy at birth for white and non-white populations. So this was that chart from, again, Poverty, Ethnic Identity, and Healthcare by Vern Bullough and Bonnie Bullough. So we will pick up again Black Americans. We wanted to spend a little bit of time, so we split it up into highest heart love. I'm your moderator and narrator, Uriel Neveu Riley. So here we go. In the middle of page 48. Even with an education, however, Black workers still face tremendous disadvantages. Many of the craft unions, traditionally the province of the highest skilled and highest paid workers, have until recently denied admission of visible minority groups into their membership. Moreover, the segregated educational system gives Black students an education that is of lower quality than that received by white counterparts who spent the same number of years in school. There are also more subtle kinds of discrimination. The Black worker may have been hired at the entry level, but overlooked for advancement. The result has been a gap between the income of the white and Black workers. The gap is narrowed between those Negroes and whites who have less than an eighth grade education or a college or graduate degree. It is greatest between those who have attended or graduated from high school or who have attended a junior college. And as jobs become difficult to find, the differential rate of the unemployment increases. In 1960, for example, the unemployment rate for white workers was 4.7%, while 8.7% of the Black workers were unemployed. At other times during the past decade, the rate of unemployment has been almost 2.5 times higher than whites, and in large urban ghetto of Watts in Los Angeles, it has gone to 3 times as high. Unemployment in the concentrated ghetto areas is particularly serious during periods of recession because many of the workers are unskilled. Inevitably, there are hundreds of young men in their 20s who, though long finished with their schooling, have never held a job or have held only a temporary training job under the Office of Economic Opportunity Programs, cut off from highly skilled jobs by lack of education and by discrimination. Negroes are often denied the opportunity to work at all because the need for unskilled workmen is dwindling. In fact, it is the changing nature of the employment which most differentiates the current minority populations from the earlier European immigrants. Though the newly arrived European also suffered from poverty, discrimination, and even segregation, they were able to find unemployment. Then, with hard work and a certain amount of luck, they or their children were able to move up the occupational ladder. Now, the bottom rung of the ladder is being cut off. Obviously, unemployed people or people whose incomes are below or near the poverty line cannot buy medical care on the open market. Since our health care delivery system is based on the ability of the individual to pay for the care he gets, the poor are in effect cut off from much of the benefit of modern medical development, and this at time when healthcare has become crucially important to survive. Before the 20th century, medical intervention was not necessarily a significant factor in determining life expectancy. Diet, sanitation, and other aspects of the environment were far more important in explaining the differential life expectancies between the rich and the poor. Today, however, medical care itself is a major factor in determining life expectancy. And this means that regardless of whether a person is able to buy, good medical care becomes of overriding concern. Most of the advanced European countries, realizing that health care itself has become such an important factor in life expectancy, made the decision to make it available through various kinds of schemes to all residents, regardless of their socioeconomic status. In the United States, the richest country in the world, with the best educated medical profession, healthcare has remained essentially a fee for service commodity, which means that those who do not have the fee cannot get the essential life saving service. Peace, highest heart, love. Miss nobody. Peace, goddess. Highest heart, love. Thank you guys for being here and reading with us. Problems of voluntary healthcare. We're now at page 50 at the top. This is not to say that some positive steps have not been taken. Voluntary prepaid health insurance has softened the impact of the system for most Americans. In 1963, 88% of the families whose income was over 7,000 carried some form of hospital or surgical insurance, and almost as great a percentage, some 79% of those whose incomes were between 4,000 and 7,000 had some form of coverage. Only 52% of the families with incomes between 2,000 and 4,000 were insured, and 34% of those with family incomes below 2,000 were covered. Obviously, the types of coverage vary, and in actuality, comparatively few had policies which would pay for all their medical costs. In spite of these qualifications, however, the average white was better off than the black, simply because the majority of non white families had no hospital insurance at all or had totally inadequate coverage. This means that they were outside of the voluntary health care delivery system. Americans, perhaps uncomfortably conscious of the fact that not all people can afford medical care, have developed a second system of charity care, which is somewhat less than second class. In the process, we have disguised this kind of medical care by saying that charity patients receive outstanding medical care. There is a rather popular saying that the very rich and the very poor are the only ones who really receive decent medical treatment. This, like most folk sayings, is only half true because the poor do not receive adequate care, as can be demonstrated statistically or by actual observation of the kind of health care offered. The pest houses and almshouses of the earlier era have been rebuilt or sometimes just renamed county hospitals. Unlike governmental hospitals in most of the rest of the world, American county hospitals still utilize a means test to establish eligibility for care. Some private hospitals, particularly those maintained by religious or charitable organizations, also admit charity patients and apply similar means tests. These screening procedures psychologically separate the poor from the rest of the population, since a patient who qualifies has the stigma of knowing he passed the means test. Whatever his ethnic identity, the charity patient is also usually physically segregated from the paying customer, and he is treated with less difference than those who are able to afford private medicine. The hospital is, however, only one aspect of healthcare, and non white patients also receive less ambulatory care. Between 1965 and 1967, white patients averaged 4.5 physician visits a year, most of which were non hospital visits, while non white patients average 3.1 visits a year. Since people whose resources are limited are most likely to turn to the physician only when they are actually ill, it was the preventive care and the early diagnosis and treatment that was most lacking. This lack of early diagnosis was revealed in a rather roundabout fashion in a recent report from the ongoing health interview survey carried out by the U.S. Public Health Service. Though it is generally known that non white patients die earlier from a range of serious illnesses and that they miss more days of work per year for serious illness, 6.6 days compared to 5.5 for the white group. It was not realized that these people simply did not know how ill they were. When questioned as to whether anyone in their family had certain specific illnesses, including arthritis, hypertension, heart trouble, ulcers, diabetes, or vascular lesions, non white patients were less likely to say yes than white were. Of the white patients, 51% reported that someone in their family had a specific chronic illness, but only 40% of the non white people interviewed reported that a family member suffered from one of the conditions listed by the interviewer. Since all the evidence, including autopsy records, indicate that poor people actually have more illnesses than the affluent, the underreported in this study seems to be able to lack of diagnosis. The ghetto resident is undoubtedly aware that he has some kind of misery, but he cannot put the concise diagnostic label on it without the help of a physician. He probably does not even know that in many cases he could be cured or at least made more comfortable. All right, we're moving along. Peace. Hi, it's Hard Love. Thank you for reading with us, guys. Peace. Happy holidays, everyone. Discrimination, very key. Discrimination, page 52. In addition to the problems faced by all poor people, any ethnic identity, non white patients also in the past have been denied adequate health care because of discrimination or segregation. And though such discrimination is no longer quite so obvious, it undoubtedly exists. When Gunnar Myrdal made his famous pioneering study of the Negro in America, which was completed in 1942, he reported widespread medical discrimination and segregation. Segregation existed not only in the South, but also in the North, though it was more open in the South. Some Southern hospitals treated both white and black patients, but segregated them in inadequate and inferior wards, or refused to allow Negro doctors to treat their patients in such institutions. Some of the larger cities had all Negro hospitals, which of course had Negro doctors on their staffs. In the North and in the West, patterns vary. In some states, hospitals were theoretically open to Negroes on equal terms with whites. But in other states, the courts had upheld the rights of the proprietors to prohibit or to segregate as they pleased. Not only was there discrimination in admissions, there was also discrimination in staffing. Though both of these subjects will be discussed later in this book, it is important to emphasize the disastrous effects they had on medical care for Negroes. A U.S. government survey of hospitals in 1963 found that Negroes were still denied access or were segregated. In fact, many of the medical care facilities which received federal grants under the Hospital Survey and Construction Act of the 1946, popularly known as Hill-Burton, practiced discrimination, and as late as 1962, a U.S. District Court found that private hospitals need not be subject to the Equal Protection Clause of the 14th Amendment. And see, stuff like this is really key. I'm going to interject just really brief because almost all of us know somebody that is still alive from 1962. Some of our parents were born before that. So that mentality, of course, has kept going. With the beginnings of Medicare in 1966, all participating hospitals were required to sign an affidavit of non-discrimination, and some 92% of the nation's hospitals were certified as meeting this requirement. In large areas of the South, however, many hospitals refused to adopt the non discriminatory provision, and at least 200 hospitals stated that they would make no attempt to comply. This included all hospitals in blocks of countries in counties, it should say, in Mississippi, northern Louisiana, southern Alabama, southern Georgia, and eastern South Carolina and Virginia. Some of these institutions have since signed so that the era of open segregation and discrimination in hospital care is now more or less ended. But subtle forms of discrimination continue to exist. Some hospital admission officers still segregate patients, but now lacking a particular section that is labeled color. They admit the patient and move him around if a white patient needs the bed next to him, or they force him to take a private room. Moreover, there are still white physicians who ask Negro patients to come to the back door so that they will not be seen by the other patients. Folk medicine. Partly because of the humiliation involved in backdoor medical care, but also because of a lack of funds and a general mistrust of traditional practitioners, folk medicine has remained important in the urban ghettos and in the rural South. Folk medicine is, of course, an aspect of any culture, but its importance varies among groups in society depending upon income, education, and even discrimination. In an investigation of the process by which prospective patients arrive at the physician's door, Elliot Friedson found that most people went through a kind of referral system. That is, they asked the advice of friends and relatives and tried to deal with their symptoms themselves before calling a physician. For well educated professional persons, this period of self treatment was usually relatively brief. But for people whose socioeconomic status was low or who felt estranged from the available medical practitioners because of cultural differences, the lay referral system was expanded. Such patients exhausted ill all the home remedies known to family members, friends, and even neighborhood unlicensed practitioners before they were forced to turn to a doctor because of the continued seriousness of their illnesses. The origins of Negro folk medicine are mixed. Some are African, while others more clearly seem to have developed in the rural South. Some of the beliefs are purely magical, while others have been empirically tested over generations and seen upon investigation to be rather logical and reasonable kinds of treatments. An example of the purely magical actions are such practices as putting a knife under the bed to cut the pain of labor and delivery, or the wearing of a variety of amulet and charms to ward off disease. The empirical procedures include massage, heat, and baths for rheumatism, and the use of various herb teas and poultries for colds. Such practices not only give comfort but help sustain the patient through difficult times. The chief repository of folk remedies in Negro community and in as in many other societies are the older women who have gained such wisdom through long experience. In today's Negro community, the older women may have worked in a hospital, although often in a menial job, or perhaps she just seems to have a knack for such healing. Middle class Negroes, like middle class Caucasians, tend to have deserted the full range of folk remedies as more professional health services have become available to them. To the extent, however, that discriminatory practices operate in preventing access to adequate medical care, even some educated people are motivated to turn to folk practitioners for advice. Peace, highest heart, love, guys. Thank you. Yes, we're reading about the holistic healers right here, right on path. You know, I've been doing the breathing and stretching and pressure points to the hands and feet and been able to help thousands of people. And this is a perfect example of this. The culture of poverty. Mm. Medical care for minorities, quite obviously, is a complex problem. And it is not only because of poverty and discrimination that there is a difference in health between black and white Americans. Public health professionals often complain that poor people, and particularly poor Negroes, do not take advantage of the preventative care that is available. The complaint of these workers has been demonstrated to be true in repeated studies. People whose socioeconomic status is low or who are non white make less use of health facilities than other people, and the kind of service they are at least likely to seek is preventative health care. The reason for this low level of utilization of available health services seems to be at least partly psychological. Slavery plus the generations of poverty and segregation have left their mark upon Negroes. This is not surprising because even when discrimination is not a factor, poverty can be debilitating to the spirit. An attempt to explain further the reasons as to why some groups make less effective use of facilities than others, various methods of classifying the poor into groups have been developed. One of the simplest and most useful of these typologies is a dichotomy used by John Kosa. Kosa suggested that there is an essential difference between acute and chronic poverty. By his definition, the acutely poor are those who had lived much of their life with an adequate income, at least by the standards of their society, but then suddenly either become unemployed or gradually become old and have to live in reduced circumstances. The acutely poor face severe problems of adjustment because they have had to find ways of coping with their new status of being poor. They are more likely to attempt to find ways to modify their condition. On the other hand, the chronically poor have spent their whole lives in poverty, or, as in the case of the Negro, poverty has often been a multi generational phenomenon. The chronically poor, accustomed to poverty as they are, have developed a whole pattern of life for coping with their condition. This pattern, which an anthropologist Oscar Lewis called the culture of poverty, is passed on from one generation to another, based on his studies in Mexico City, New York, and San Juan, Puerto Rico. Lewis argued that the culture of poverty transcends racial and national lines, and that some of the traits that have been attributed to nationality groups are actually common to all people caught in this condition. The culture of poverty must of necessity exists inside of another more affluent culture because the perception of being poor depends partly on knowing that there are others who are not poor. This culture is marked by a low level of political power and participation in the decision making aspects of society. In the families he studied, Lewis also found a low marriage rate, a high rate of illegitimacy, and many families headed by women, all of which are also common characteristics among the American Negroes whose socioeconomic status is low. It is the psychological characteristics of the culture of poverty which seem to be most important for healthcare. Lewis found that fatalism and helplessness, dependence, and feelings of inferiority were common. He also found that the time of orientations tends to be concentrated on the present rather than the future, as is the case with middle class society. The problem of getting through a day is enough without trying to bother about planning for the future. Others, mostly sociologists, have described the negative outlook of the people of the slum in terms of alienation. The poor feel cut off from the power to control their own lives and have no hope for the future improvement in their condition. With such an outlook of future, time orientation would be foolish. So most poor people try only to deal with their problems at hand. The middle class orientation, on the other hand, is linked to a system of deferred gratification because such planning has paid off. But the man who lives on the edge of starvation or disaster has never learned the value of deferring, so he does not save money, or in the case of health, does not seek preventative health care. The importance of alienation in describing the negative outlook of the poor has been the subject of considerable empirical research. It was found in one study that mothers who felt socially isolated and believed that they lacked the power to control their own lives or those of their children were less likely to bring their children into the well baby clinics than mothers who felt less powerless and less isolated from their supports of friends and family. In another study, it was found that the negative feelings of despair and alienation, as measured by the anomie scale constructed by Leo Sproul, acted as barriers to mothers seeking prenatal care as well as immunizations for their children. There, there is a simple logic in these findings, since it would seem that the person who feels that he has no control over what happens to him would not see the value in taking the necessary steps to obtain preventative care, health care. In his own mind, his health would be controlled by fate or other outside forces rather than his own actions. Following this line of reasoning, a comprehensive study of psychological barriers to preventative health care was done by one of the authors, Beebe, during the winter of spring of 1970. In 1971, 800 mothers from the poor neighborhoods of East and South Central Los Angeles were interviewed. Those with minority status, incomes below the poverty line, and meager education tended to have a much more negative outlook on life. They felt powerless, isolated, and hopeless. These feelings, in turn, were related to a low level of utilization of preventative health care services for themselves and their children. This meant fewer checkups, less dental care, fewer immunizations, and less prenatal care. However, the most significant correlations were with the various indices of effective family planning. So key. Family planning seemed almost impossible for the alienated Black or Mexican American woman from a poverty neighborhood, and even when services were available at a nearby clinic. Numerous previous studies have shown the correlation between effective family planning and socioeconomic status. But alienation as a factor is just starting to be investigated. Lee Rainwater pointed out that a sense of stability and trust in the future were essential preconditions for consistent family planning. And since these conditions were not present among the poor, effective long range planning is rare. Race also is a factor. Negro women whose socioeconomic status is low have more difficulty with family planning than white women at a comparable level. In spite of the fact that the Negro woman desired a limited number of children, they ended up giving birth to more. This emphasizes that although poverty itself is important in creating the negative feelings that deter planning and preventive health behavior, segregation and discrimination magnify the effects of poverty. In a study of housing patterns, done earlier by an author of the book of this book, it was found that segregation was a more important factor in creating feelings of alienation than simple poverty. Middle class Negroes were studied so that poverty was not a current factor in their lives, although many of them had been poor in the past. Central to the findings was the fact that experience with segregated schools and a segregated lifestyle was more strongly related to current than past poverty. Unfortunately, these feelings of alienation then in turn acted as barriers to integration, so that segregation and alienation seemed to relate to each other in a circular fashion. These findings do not necessarily contradict the idea that there is a culture of poverty transcending racial and national lines, but they do suggest that the experience of American Negroes with discrimination of various sorts may have added to their feelings of fatalism, hopelessness, and powerlessness. Since such subjective factors as barriers to preventative health care, it seems obvious that it is necessary to have a multifaceted program to cure the inequalities now existing between white and non white citizens in order to deal completely with the poor health of Black Americans. Obviously, preventative health care is more important to some kinds of illnesses than others. We as we that we as yet can do little to prevent many of the degenerative processes associated with aging. However, an increasing number of contagious diseases can be prevented by immunization. In 1970, for example, there were several outbreaks of diphtheria in large urban areas which need not have occurred if immunizations had been available to all, or if we could find a way of overcoming the powerlessness and hopelessness, which keep the people of the ghettos and barrios from bringing their children in for injections. Perhaps the most obvious improvement would take place in the maternal mortality. Mm. In 1915, the mortality rate for non white mothers of 105.6 per 1,000 births exceeded the rate for which by 75%, 60 per 1,000. Woo! That's super big number. 105.6 per 1,000 births exceeded the rate for whites by 75%, 60 per 1,000. Since that time, the overall maternal death rate has fallen due to the improvements in the nature of hospitals and in medical and nursing knowledge. However, as the rates have fallen, the gap between white and non white mothers has grown until today it is 300% higher. 7.2 per 1,000 births for the non white and 2.2 per 1,000 for the white mothers. To equalize the rates, the whole nature of healthcare delivery care system would have to be changed. Although some statistical improvement undoubtedly could be made with the present system if ways could be found to encourage the non-white mother to seek more prenatal care. One of the most obvious areas in which preventive medicine could be effectively applied is in the field of dentistry. Surprisingly, perhaps for hereditary reasons, Negroes suffer less from dental caries than do white Americans. The first indication of this was found by R.W. Hyde in his study of draft recruits in World War II. Although his results have since been replicated, only Chinese Americans had fewer carries than American Negroes. Negroes as a group, however, visit dentists much less than most other groups in American society, largely because dentistry is so expensive and associated with middle class status. In a sociological study of attitudes towards illness, E.L. Coase divided his sample into three socioeconomic groups. 1. Business and professionals. 2. Skilled and semi-skilled workers. And 3. Unskilled workers. Almost 95% of the Class 1 households reported they had a family dentist, but only 12.5% of the Class 3 families had established such a relationship. In fact, 50%, 57% of the individuals in Class 3 and 9% of the individuals in Class 2 reported that they turned to dentists only to have a tooth extraction. Coase study is undoubtedly indicative of general attitudes towards dentists. And since so many Negroes are trapped in the culture of poverty, they get very little preventative dental care. Additional evidence for this assumption comes from the fact that Negroes have a much higher proportion of periodontal disease than whites, something which can be treated early by a dentist and often even prevented. That's right. In one study in which a scale ranging from 0 to 8 was used to rate the amount of periodontal disease, the white population was given a score of 1.1, while the Negro population was rated at 1.6. Concluding comments. Black Americans. This is so deep. Concluding comments. Thank you guys for being here. We did it. Here we go. Concluding comments. In summary, it should be evident that the health problems faced by the large proportion of the Negro minority community are monumental. In part, these difficulties can be understood through looking at the past history of American Negroes because this past has left its mark on today. Three variables seem most important in explaining the fact that mortality and morbidity rates are higher for Negroes: poverty, discrimination, and the social psychological barriers which tend to keep people from using the services that are available. All three of these factors interact and reinforce each other, just as poor health care interacts with and reinforces the other problems faced by Black Americans. Page 59. That concludes Chapter 3. Poverty, Ethnic Identity, and Healthcare by Vern and Bonnie Bullough. Thank you all for reading with me. I love you. I love you. So that was deep, right? Yeah. It plays a huge part in healthcare, how people look at you, you know. They say don't judge a book by its cover. But the reality is, people judge people by the way they look. So we have to honor where we are. We have to honor who we are and where we come from. Stay the glitch. There's nobody that can do what you do. That's what I've learned on this journey. There's only one you. There's only one me. And we're all a piece of the puzzle. Right? Thank you so much. Happy holidays, guys. If y'all would love to donate, show love, man, thank you so much. I really, really honor and appreciate all of you. So, if you are in that spirit, Cash App is $8,E-A-L-I-N-G-U-R-I-E-L. Your healing, Uriel. Thank you for asking, and thank you for all the love. I really appreciate y'all reading these books, because we have to educate ourselves. We have to educate more people. You know, there's too many people that don't read. I remember growing up, we used to do cross-referencing in the Bible, and as well as in school when we're doing book reports. This is a very, very important skill to coming down to facts and learning how to get your foundation information that you build on top of, because lies just crumble. So, honor and love. Thank you so much. Yes, right, man. Thank you. You are such a bright, bright, bright spot in the world. Keep shining your light, Miss Nobody. You're such an angel. Thank you so much. Happy Wednesday. Peace to everyone all over the U.S. as well as all over the world. We're doing it, right? We have the power. That's a fact. One love. Thank you. Yes, we have the power. Yes. Keep reading.